So
Nancy.
you guys could take it away.
Thank you, everybody, for coming today. Feedback. Oh, maybe now it's better. Just wanted to thank everybody for being here. We're going to do a little bit of a handoff between the three of us. We're going to each take a certain section of the webinar. To let you guys know, this is an introduction basically to PDPM so that we all have a ability to follow through. I'm having a little technical difficulty on my end, so hang on. Why is it not working? There we go. Okay. Sorry, technical difficulties. All right, so this is our introduction to PDPM. So what is PDPM? The patient-driven payment model. That's where PDPM comes from. It is a new case mix classification system for classifying your skilled nursing facility patients that are going to be in a Part A covered stay into payment groups under the SNF prospective payment system. So we're still under the prospective payment system, but there's going to be changes to how patients are categorized. So effective October 1st, PDPM will replace the current case mix classification system, which is the resource utilization groups, or RUGs 4. So first of all, why is CMS changing to PDPM? So the patient-driven payment model will improve payments made under the SNF PPS in the following ways. Improves payment accuracy and appropriateness by focusing on the patient rather than the volume of services provided. So under current RUGs, we're getting a reimbursement based on the intensity of the amount of therapy minutes. Now it's going to be based more focused on the patient. Okay. Significantly reduces administrative burden on providers. There's going to be a lot of differences, such as an example would be many less MDSs that are going to need to be filled out. So that's one way that they're reducing the administrative burden on the provider. It also improves SNF payments to currently underserved beneficiaries without increasing total Medicare payments. So this is supposed to be a budget neutral system. So how will the SNF classify patients into the payment groups? No more RUGs. Okay, so instead of classifying first under RUGs, right now we're classifying first for therapy at least under the amounts or intensive minutes of therapy. Nursing has basically their clinical components, okay? So under this new PDPM system, there's going to be 5 case mix adjusted components. They're all based on data-driven, stakeholder vetted patient characteristics. So there's going to be a component for physical therapy, occupational therapy, speech therapy or speech language pathology, nursing, and then non-therapy ancillary services. Now, the non-therapy ancillary is based on their comorbidities, so it's going to be grouped based on that for whatever comorbidities were going on. PDPM also includes a variable per diem adjustment that will adjust the per diem rate over the course of the stay. We'll get into that a little bit later in the slide presentation, but suffice it to say, with the classifications, you're ending up with a per diem, which is the rate of pay every day. But there is going to be some variability to that rate based on this adjustment. Under PDPM, each patient will be classified into a group for each of the 5 case mix adjusted components. So there's PT, OT, speech, nursing, and non-therapy ancillary. Each component utilizes different criteria as the basis for patient classification. For PT, it's a clinical category and then a functional score. For OT, the same, clinical and functional score. For speech, there is present acute neurological condition, speech-related comorbidities or cognitive impairment, mechanically altered diet, and swallowing disorder. The nursing component has the same characteristics as under RUGS 4. And then there's the non-therapy ancillary component, which is based on their comorbidity score. So how will PDPM classification be different than RUGS? So under PDPM, patient characteristics will be used to predict the therapy costs associated with the given patient rather than relying on service use or intensity of services. For the PT and OT components, we have two classifications that are going to be used. There's the clinical category, and that's basically derived from a mapping system from their ICD codes, so diagnosis driven. Then the additional component is their functional status. And that under RUGS for PPS has been always calculated their ADL score by section G. Now under PDPM, that is changing to GG. And I will hand the microphone now over to Natalia to continue the slides.
Hello, everybody. So thanks, Joanne. So the next step is just to make sure that the PT and OT teams have a really good understanding of the expectation under PDPM. So PDPM advances the CMS goals of using standardized assessment items across payment settings by using items section GG of MDS as the basis for functional assessments. So as Joanne had mentioned before, they were using section G under the MDS. Now it's going to be our responsibility to make sure that we calculate the patient abilities under GG very accurately. So it's not something new. You guys have been doing GG for a while, and there's going to be some further training for GG to make sure that everybody really understands what we're expecting under PDPM. So under GG, there's going to be a score of 0 to 4 for 2 bed mobility items, 3 transfer items, 1 eating item, 1 toileting item, 1 oral hygiene item, and 2 walking items. So these are scored at eval under PT and OT. So what are the differences between G and GG scoring? So they're actually opposite. GG is reversed from G score. So an increase in the G score means an increase in dependence. An increase in the GG score indicates increased independence. So if you're looking just purely at the number, 0 to 4 under GG is opposite of what the G score was. Now under PDPM, there's not a direct relationship between increased dependence and increased payment. So right now under RUGS, if somebody has a higher need physically, there's a higher ADL score resulting in a higher reimbursement. And so why are we using GG rather than G for functional scoring under PDPM? It's more comprehensive. It aligns better with payment model and other quality initiatives. GG data has been validated and reliable since you guys have been doing it for a while now. It's a good predictor of both PT and OT utilization, and GG items will be coded the same, so there are no changes in GG. Now this is going to be something that we're really going to have to focus on over these next few months, is making sure that we're coding correctly, that we're coding accurately, and that we're not missing any items. So functional scores will be assigned 0 if there's any missing sections. Any incomplete responses will be a 0, and a dash is considered a 0. So right now, I think a lot of the supervisors are just kind of making sure when an eval is done, if there's a missing item, that's what we can do, is just to make sure that any staff that's kind of consistently missing anything, just to make sure that everybody understands that there has to be a value. Now, the answer not attempted due to environmental limitations is something that we're seeing pretty frequently in PCC when we're looking through section GG. So make sure that you realize that if this response is used, it's also going to receive 0 points. Resident refused, not applicable, not attempted, due to medical condition or safety concerns also will result in 0 points. We also get 0 points if we code dependent. Now CMS determined that dependent was found to have a different PT and OT utilization than patients that required substantial or maximal assistance. Why is PT and OT payment higher for higher functional independence in some cases? So the best way that I can explain this is if you picture like a bell curve. Patients that are really, really, really low level or dependent aren't going to need as much therapy services, as opposed to patients that are very, very high level, conversely might need less services. But those patients that are not too impaired, according to CMS, will have a higher need of utilization for therapy services. So PT and OT utilization is highest for patients with moderate functional independence. So like I said, the low level may be too impaired and high level may require less care. CMS believes that PDPM accurately assigns payment according to observed relationship between function and PT and OT utilization.
And again, going back to the slides of, how they figured that out, this is all based on the data. So they've already figured out that these are the patients that need more services.
All right, and at this point, I'm going to hand over to Nancy Rowan.
Hi, everybody. So we'll talk a little bit now about speech therapy. For the speech therapy component, PDPM uses a number of different patient characteristics that were predictive of increased speech therapy utilization costs in the past under the RUG system. They include acute neurological clinical classifications, certain speech therapy related comorbidities, the presence of cognitive impairment, the use of a mechanically altered diet, the presence of a swallow disorder. Cognitive scoring. So there is a cognitive scoring component factored into PDPM. And the patient's cognitive status will be assessed in exactly the same way as it was under the RUG system. And it'll be assessed via the BIMS or a staff assessment. Scoring the patient's cognitive status for purposes of classification is based on the cognitive function scale, which is able to provide consistent scoring across the BIMS and staff assessment. Cognitive measure is not a factor for PT and OT components. It's only a factor for speech. The score that is going to be used at our facilities is the BIMS, which is on the MDS, which stands for Brief Interview of Mental Status. The cognitive levels, cognitively intact, will score 13 to 15. Mildly impaired cognitive status is 8 to 12. Moderately impaired cognitive status is 0 to 7. Severely impaired is just a dash. Or it could also be compared to the cognitive performance score, which is also utilized to determine the person's cognitive status. The cognitive status will be assessed by the Alden staff within the first few days of admission to determine that score. Variable per diem rate. Constant per diem rates do not accurately track changes in resource utilization throughout the stay and may allocate too few resources for providers at the beginning of a patient's stay. For PT, OT, and NTA, or non-therapy ancillary service components, the case mix adjusted per diem rate is multiplied against a variable per diem adjustment factor, following a schedule of adjustments. For PT and OT, the variable rate is less 2% after day 20, and then it also decreases 2% every 6 days thereafter. PDPM assessment schedule. There are 2 required PDPM assessments scheduled. The 5-day scheduled PPS assessment, which covers days 1 through 8, all covered Part A days until Part A discharge. The other required assessment is the PPS discharge assessment, equal to the end date of the most recent Medicare stay or end date. There's also an interim payment assessment, IPA, which is an optional assessment, ARD, of the assessment through Part A discharge, unless another IPA assessment is completed.
So basically, there's no more 14-day, 30-day, 60-day, 90-day. It's beginning and end or an optional interim assessment.
Surgical history. So the major surgical procedures that occurred during the qualifying inpatient stay will be used to classify patients into the PT and OT case mix. There are some FAQs that we'll go over now. How will PDPM affect Medicare replacement insurance? Each Medicare replacement insurance plan will decide on their own whether or not they will incorporate PDPM into their payment system. How will PDPM affect NOMNC, which is Notice of Medicare Non-Coverage or Denial Letters? Regarding that, there is no change. Will Medicare still pay for skilled therapy services under PDPM? The answer to that question is yes. Skilled therapy services will still be reimbursed by Medicare under PDPM. While PDPM does not change the manner in which patients are classified into payment groups under the SNF PPS, it does not change any of the coverage criteria or documentation requirements associated with the skilled therapy service coverage under PDPM. Most importantly, PDPM does not change the care needs of a SNF patient, which should be the primary driver in all care decisions. This includes the type, the duration, and the intensity of all skilled therapy services made on behalf of the SNF patients. What if my patient is only receiving PT services? Will I still receive a payment rate for OT and ST components? Yes. Patients are classified into a payment group for each of the therapy components, regardless of whether or not the patient is receiving services within that particular discipline. Group and concurrent therapy. Under PDPM, we use a combined limit, both concurrent and group therapy, to be no more than 25% of the therapy received by SNF patients for each therapy discipline. The current definitions are: concurrent is one therapist with 2 patients doing different activities. Group therapy is one therapist with 4 patients doing the same or similar activities. The group definition is still under consideration and may change under the final rule. 3-day break. If there's a 3-day break in therapy, will an end of therapy be required under PDPM? Under PDPM, there are not a required days of treatment per week. Thus, no end of therapy will be required. However, there is still an expectation that daily skilled care requirements for SNF Part A patients will be observed. Definition of skilled services. Skilled services must be provided directly by or under the general supervision of these skilled nursing or skilled rehab personnel to ensure the safety of the beneficiary and achieve medically desired results. Skilled services must be ordered by a physician, performed by or under the supervision of professional or technical personnel, rendered for an ongoing condition for which the beneficiary also received inpatient hospital services, or for a new condition that arose during the SNF care for that ongoing condition. It also requires skilled nursing services or skilled rehabilitation services on a daily basis, which, as a practical matter, can be provided only in a SNF on an inpatient basis. Thank you so much for listening to our presentation.
So we just want you to know this was just a brief presentation taken directly from the CMS website on the frequently asked questions regarding PDPM. So this is one of our initial presentations. The next thing we'll be working on is a more detailed presentation on section GG, like I had mentioned before. And anytime any of you have more questions, the supervisors do have the frequently asked questions in their emails. So there's a lot more detail, and the numbers that are in the slides are directly taken from those FAQs. So if there's a certain slide that you had, refer to that handout, and there's a lot more detail. Thank you, everybody, for your participation.
We'll also send you the link for the FAQs on the website as well. So just in case, I know that you all have a copy, but we'll send you the link as well. Are we opening for questions or? Okay. So we won't be opening for questions for today, but as we call you guys, we can definitely answer questions. You can email us. We're also within, when we come out, we can also review any questions that you have from the frequently asked questions. Okay. We don't want to take any more of your time. We thank you so much for your attention and your attention. Have a great day, everybody.
Bye-bye.